can let people income.
Prior to the dawn of democracy, there were very few opportunities for people living in townships to access quality, private healthcare at affordable rates.
It was difficult then to get into private practice because most private hospitals only admitted white patients.
You know, those days are apartheid days. Patients were allowed in the private hospital, but I was not allowed to go and see the patients there. At one stage, I was the only black specialist in this country in private practice. I was a pioneer going to white hospitals. I could see the reverse. That black doctor is here again.
Skilled black medical staff were employed at government and private hospitals far away from where they lived. And the community who required private healthcare services had to travel long distances to hospitals located in formerly white areas, often at considerable expense. In the late 1960s, a group of visionary businessmen, including Dr. G.M. Piche and Mr. Richard Maponya, under the leadership of Dr. N. Motlana, formed a company whose purpose was to establish a medical scheme and private clinic to serve the disadvantaged communities. In 1985, the group opened its first private hospital, Lesedi Clinic, now renamed Dr. S.K. Matseke Memorial Hospital, finally realizing their vision of bringing private quality healthcare to township areas. That led to the formation of the Clinics Health Group in 1992. It was the futuristic ambition of Dr. Peter Matseke that saw the current and continuing growth of Clinics Health Group to greater heights. Clinics also facilitated the advancement of previously disadvantaged doctors by enabling them to open their own specialist practices in these underserviced communities. 30 years later, Clinics continues the legacy by being a respected healthcare group consisting of 6 private, state-of-the-art hospitals located in Soweto, Johannesburg, Vosloorus, Vlieningen, and Mafikeng. Together, these hospitals have over 1,500 beds and 23 operating theatres. Facilities include ICU beds, 24-hour emergency units, renal dialysis, mental wellness services, and 24-hour urgent care. Clinics continues to attract top healthcare professionals, which enables us to meet our mandate of providing a high standard of healthcare products and services, quality patient care, and friendly service. Clinics is committed to providing economic opportunities by ensuring that procurement is outsourced to local businesses, supporting entrepreneurs and ensuring a bright future for all. We continue to be administered by a team of diverse and highly skilled medical practitioners who, being rooted in the community, know just what you need to thrive. Clinics Health Group. You are family.
Good evening, colleagues, and welcome once more to our weekly webinar, where we've been endeavoring to give you the best medical knowledge since the commencement of the COVID-19 pandemic, when we went into lockdown. It's been a pleasure to be with you every week. since that time when we started these webinars. And we thank you for your continued support, that you are coming in every week to listen to great speakers who come from different backgrounds, different disciplines, both in the public and the private sector, who are empowering us with medical knowledge, medical education knowledge. And so we just want to say thank you once more and welcome to our weekly webinar brought to you by Clinics Health Group. As usual, these webinars are CPD accredited, and so we request that when you log in, please give us your details, your name, surname, contact details, and also your registration number. For those who are with HPCSA, you will get your CPD points uploaded directly, and you get your points. You don't have to do anything. And the other colleagues from other regulatory bodies, you get certificates of attendance when you give us your full information. And we know that there are others who are not healthcare professionals who are quite keen on getting a continued medical education from these webinars for patient and community information, and also advancement in health awareness. So this evening we continue, and we also request that when you log in, please mute yourselves, and so that we improve the quality of the feedback and reception, that sometimes we get a poor internet connectivity from time to time, and load shedding has not made things easier. And note that these webinars are also streamed live on YouTube. So at any time after the presentation, you may be able to go back and check the webinars and the presentations. At all times, I know that some people want to get copies of the presentations, but if you are on YouTube, you should be able to access them freely. But otherwise, if there are those who want to get copies of the presentations, we'll check if the presenters are keen on giving you the presentation. But otherwise, we encourage everyone to check YouTube, and also do like us on YouTube so that you get notified about future webinar presentations. So this evening, we're excited to have one of the specialists in the field of medicine who's got quite an experience in his field, Dr. Sindeep Bhana, who's a principal specialist and head of endocrinology and metabolism at Dr. Sindeep Bhana Academic Hospital. He's also the head of diabetes, endocrine, and metabolism in internal medicine at Dr. Sindeep Bhana, where he is involved in several publications, poster presentations, and numerous pharmaceutical trials. And I'm glad that we have him this evening, and he tells me that he's on a sabbatical, so we're actually eating into his time of research that he's put aside for this past 6 months or so. So Dr. Bhana is an alumnus of the University of the Witwatersrand. He's currently the founder and director of the Center for Medical Excellence in Waverley. In 2004, he received a gold medal from the University of the Witwatersrand for teaching excellence. He's also the recipient of the highly respected Philip Tobias Award for teaching. Dr. Bhana has appeared on multiple media shows on a wide range of topics, and we have his qualifications, MSHB, FCP, SA, and MED, and also a certified endocrinologist. He's going to be speaking to us at a new look at type 2 diabetes mellitus, and we're excited to have you in our midst, Sindeep. Thank you very much.
Thank you, Dr. Bila, for that introduction. So I hope the screen is showing from my side.
It is, yeah.
Okay, good. So I was asked to give this talk on short notice, and my wife always says I like talking, so I didn't really mind. Today, I've given the topic for the discussion today is a new look at type 2 diabetes. And I say a new look because we're at an age, and I need you to keep in mind that we are looking towards remission. So for all of my university career, we were taught it's a chronic condition, you manage it, and as you get failure in HbA1c control, you try and up-titrate. And so the idea is to move away from this up-titration and move towards going for remission. So the reason why we're all here is that diabetes is a growing epidemic. in the world, and of course in South Africa as well. So 2015, we were sitting at about 2.3 million South Africans suffering with diabetes, and that represented at the time about 7% of the population. The worrying data is that in South Africa, about 61% of our patients remain undiagnosed. In the rest of the world, we're looking at about 50%. So 2035, we were projected to have about 4 million patients with type 2 diabetes. And it's said to say that we've reached those levels already. And so that's been true for every target that was ever set by any statistician with regards to any figure in terms of diabetes. We've always, world over, seemed to have reached those milestones that they've set way before they were set. And so it tells us that it's not only an epidemic, but it's growing at an alarm rate. And one of the driving factors for type 2 diabetes is the obesity. And obesity is going away because at this point in time, we've got over 1.2 billion people on this planet that are sitting with obesity. And if you look at just being overweight, then we're looking at closer to 40%. Now, 56% of people in South Africa are overweight. That's data showing in terms of our female population. The data I've taken sabbatical to publish is actually showing the figures close on to 75%. In terms of males, we're looking at a close on to 31% of our males are overweight. So as an introduction, Defronzo, who doesn't need any introduction, if you look on the top left, in 2009 already highlighted the need to address all 8 core defects in terms of diabetes. And at the time, they named it the ominous octet. And to have a comprehensive approach to managing type 2 diabetes, we needed to understand the defects. So if you go to the top right-hand corner, the blue one, a new beta-centric model expanded the number of pathological targets from 8 to 11. And so this is a culmination of having a better understanding in terms of the involvement of genetics and the environment. And now we talk about the egregious 11. And all of this conspires to cause hyperglycemia. So if you look on the bottom left, the diabetes management guidelines have all begun to emphasize the importance of achieving glycemic control and trying to use medications that are going to have complementary pathways. And that treatment needs to be targeted not only to improve HbA1c, but it needs to have a beneficial profile in terms of weight. And it must have the potential to prevent micro and macrovascular complications. So gone are the days where we were just trying to target an HbA1c. On the bottom right, we're looking at optimal therapeutic strategies used to patient individualized regimens. So in the past, we had exercise and diet for everybody. If the HbA1c was not on target, we added metformin. If that wasn't enough, we added an SU. If that wasn't enough, we went in a stepwise approach to insulin. Whereas nowadays, we've got to individualize the regimens. And we're going to try and target as many of the 11 pathways that are important in terms of dealing with the pathogenesis of the type 2 diabetes. And when we use agents, we're going to try and use as fewer agents as possible with the least amount of side effects. So they've set us practically impossible tasks. So let's look at the 11 different interlocking pathological pathways that all conspire to get to type 2 diabetes. So we all know about the importance of the pancreatic cell. Here, the beta cell is very important. It produces insulin. And our understanding was always that insulin is what controlled glucose. And that's the common denominator, and we needed to address it. What's important to understand is also the effect of the incretin effect on the beta cell and on patients with type 2 diabetes. And the incretin effect is that effect that we see when we take a fixed amount of glucose and give it to the person via mouth. So it's like oral glucose tolerance test. And we take the same amount of glucose and we inject it peripherally And we note that there's a difference in the insulin spike, and that is noted as the incretin effect. And it's driven by two hormones, one called GLP, glucagon-like peptide, and the other one is GIP. What we mustn't forget is the importance of the alpha cell in the pancreatic, in the pancreas. And the alpha cell produces glucagon, which is very important in terms of managing hypoglycemia. So the end effect of pathological pancreas is that the beta cells don't produce enough insulin, the alpha cells don't produce enough glucagon, and then we have this net abnormal incretin effect, which is going to lead to hypoglycemia. We've always known about the importance of insulin resistance, and we know that organs like the liver, muscle cells, and adipose tissue use up glucose, and that when they become resistant to the signals of insulin, we describe that as insulin resistance, and then the body responds by producing a lot more insulin to try and force the glucose into those cells, and we end up with hyperinsulinemia, which comes with its own problems. We now know that the brain plays a very important role, especially the hypothalamus, and it has many neurotransmitters that all conspire to increase appetite in the diabetic patient, and it decreases the reward center, and there's also an increase in sympathetic tone. The end result is decrease in satiety, the sensation that you're actually full, so these patients end up eating more. And of course, you have an increase in the appetite center as well. So the net effect is more calories go into the system. The importance of the gut microbiome. So my interest in the gut microbiome started in about 2003. At the time, people thought it was just a farce driven by mainly homeopaths. But you can see the literature now. I think, if I'm not mistaken, there's close on to 9,000 publications on a monthly basis, publicizing in some of the big journals the importance of the gut microbiome. And here, its role towards insulin resistance and how it decreases the production and the secretion of GLP, which is the important incretin hormone that I spoke about. The importance of low-grade inflammation is the cause of type 2 diabetes, and its effect on the beta cell is an important role as well. In terms of stomach and the small intestines and the role of amylin. Now, we don't have it in South Africa, but there's a product called pemvidutide, which works on amylin and has an effect on hypoglycemia. And then we mustn't forget the emergence of the kidney in terms of type 2 diabetes. So most of us non-diabetic people, once our glucose levels goes above 10 millimoles, we will start spilling out the glucose into the urine and discard it that way. In patients with type 2 diabetes, that threshold is actually increased. So the net effect is that the hypoglycemia is a bit higher. And so the kidneys are conspiring to hold on to the glucose in these patients rather than letting it go. And here we speak about the importance of the SGLT2 pathway. It is an insulin-independent pathway. So it's important to try and target as many of these pathways that are contributing towards hypoglycemia. And so it's important that from the beginning, we look at combination therapy. So the old stepwise approach where we stratified first-line therapy, second-line therapy, third-line therapy is now gone. And the reason for that is this old approach that I was taught at medical school is looking to treat to failure. In other words, we set ourselves a goal, we give treatment, the patient's going to end up failing, then you move on. That second therapy then fails, you move on. And remember, that's how we used to treat rheumatoid arthritis. We used to just give pain management, and we'll say, oh, if it gets very bad, we're going to start giving you some of the disease-modifying drugs. And then we realize that, and too late, that by then the patient already has joint deformities, and we end up chasing our tail. And so long before endocrinologists, the rheumatologists realize, hit the condition hard and try and bring the inflammation down under control as soon as possible. And then we can talk about decreasing therapy. So we are now starting to take the same approach with type 2 diabetes. And that's why I started off telling you it's important to always have in your mind diabetic remission. And that's what you need to aim for. So going back to these pathways, initiate with combination therapy, avoid this whole first line, second line, third line therapy approach, because that creates competition. I find amongst our colleagues, we'll say, oh, is that product better than this one? Or what do you think? What's your favorite? Is it metformin? Is it an SU? Is it SGLT2? It's not about which is the best drug, which is about the favorite drug. It's about, are you using the right tool to address the right pathology? And here, if the pathology has 3 or 4 or 11 components, how many of those are you targeting? Because there's never going to be one product that targets everything. And so complementary use of products to treat as many of the pathological pathways is important rather than just trying to do salvage therapy. What's important is that most of us, no, not most, all of us were trained at one point or the other in government hospitals, and then we develop our habits there. And, you know, the metformins, the SUs, and the insulins have always been available in state. However, here I need to let you know that we need to try and avoid SUs and glutamides as much as possible, because although they benefit in bringing down sugar levels, they do it at the cost of hypoglycemia, but also it makes them put on weight, and their benefits are outweighed by the risks that they. So hypoglycemia and weight gain is what you need to avoid at all costs, and it's very important to keep that in mind. So what are the challenges that we all face? Because I can tell you about 60% of patients that are admitted for anything, whether it's a hip replacement or some kind of a kidney problem or kidney issue, all have the risk of having type 2 diabetes or are pre-diabetic. So at one point or the other, we're all going to have these problems. So patients don't like complex regimens, nor do doctors. We fear it. Patients don't like needles. They don't like injectables. They don't like hypoglycemia. They're afraid that with type 2 diabetes, 85% of them are already overweight, and most of the old therapies will cause the weight to go up. So they don't like weight gain. And so there is poor efficacy. So it's one of the barriers we face as healthcare practitioners, is that our patients are not very compliant, and there are reasons for that, and we're going to go through it. Our patients and some of the doctors judge, and there's a feeling of failure because this condition is such that it's always going to progress historically with the kind of treatments we've used. So they always get told, oh, you're not at H1C target. Oh, we're going to have to go up. Or you should have walked a bit more. Or you should have tried to lose weight. So there's this feeling of failure. Cost is an important component to this. The complex regimens, and on average, diabetic patients are on about 8 agents. So, of course, they're going to be forgetting. And so in terms of healthcare practitioners, insufficient use of clinical guidelines, lack of keeping up with diabetic knowledge, which is expanding at a phenomenal rate. And so poor health literacy, all of this provides a barrier. And that is why no matter where you look in the world, whether you're dealing with type 1 diabetes, whether you're dealing with type 2 diabetes, we are not reaching target. Even in the best of places with no restriction on resources, the old stepwise approach of exercise, metformin, SU, and insulin set us a target of an H1C of 6.5 if you're in Europe, or 7 if you're in the USA, and 20, 30 years down the line, we're still not reaching those targets. So you can cast your eye anywhere on this map and you can see we're not doing a good job. So why are we bothering? Why do we even manage diabetes? So we know why we manage pneumonia, because the patient's going to end up dying. We know why we manage HIV, because they're going to end up dying. So in diabetes, our patients end up dying as well. In fact, more patients die of type 2 diabetes on a daily basis worldwide than road accidents, TB, HIV, and malaria put all together. So what we're trying to do is prevent microvascular complications that you've seen in the blue, and in the gray, macrovascular complications. So the microvascular complications are very costly. They cause blindness, they cause diabetic disease, and the cost of dialysis is very costly, and there's limited slots, certainly in the state. It causes neuropathy and a very high rate of limb amputations. So that's microvascular complications. From a macrovascular complications, the dreaded big heart attacks, strokes, peripheral vascular disease, these are all the dreaded complications, and diabetes plays a major role to it. So why do we need to have this new look? Because we realize that diabetic patients are at a high risk of cardiovascular disease. And so a diabetic patient is 2 times more likely to have cardiovascular disease than the general population. That the life expectancy is reduced by 12 years in a diabetic patient who has established cardiovascular disease. Now you must know that's 12 years in somebody who's 60 years old. And on average, if the person's going to live to 82 and you've got 22 years left and you've chopped off 12, that's more than half. And so being diabetic, having an underlying cardiovascular disease is no joke, and the mortality rates are very high. What's important and what's emerged as a big cardiovascular component is heart failure. If you spoke about type 2 diabetes and macrovascular complications 20 years ago, heart failure didn't even feature. And now we know that diabetic patients are 2 to 5 times more likely to develop cardiac failure. And that diabetes confers a 60 to 80% greater probability of cardiovascular death, especially when there's established heart failure. So these are dire stats, and it's not comforting. What's difficult is that in the past, we had set an HbA1c target for the whole world, and it was easy. It was 7. What's made your life more difficult is that now the person diagnosing the condition works out using various factors what the target's going to be. So if you look to the left, if the psychosocial considerations of a patient who is highly motivated, knowledgeable, and capable of taking care of themselves, you're going to go for a lower HbA1c. If the resources and the support systems are favorable, you're going for a lower HbA1c. Risk of hypoglycemia is low, go for a lower target. If the duration of type 2 diabetes is short, go for a lower HbA1c target. If the life expectancy of this patient is long as opposed to short, if they've got other comorbid diseases, you go for a lower HbA1c. Absence of cardiovascular or microvascular complications, you go for the lower HbA1c. Anyway, I'm not going to go through the whole list. So there's multiple factors that will decide whether this young 80-year-old motivated is going to go for an HbA1c of 6 compared to somebody who's 58 but already got cardiovascular issues, not knowledgeable, or if knowledgeable, they're not willing to play game, you're going to be targeting maybe a 7.5. So this is what's making it difficult, and you definitely need to have a new look at how you're going to be approaching it. And in the past, we had a very glucose-centric approach to managing diabetes. We only worried about sugar levels. However, the worst thing that happened to this condition is that we called it diabetes, because now we're all focusing on sugar. And actually, type 2 diabetes is a metabolic condition, and that blood pressure, cholesterol, weight, and sugar all play an equally important role in this condition. And so we mustn't forget the importance, as the first column shows, in terms of targeting blood pressure, that each diabetic patient needs to target a lower LDL, that these patients should not smoke or vape, that the targets, whatever you're setting the targets, should try to be achieved. And then depending on the risk, the patient may or may not require antiplatelet therapy. So it's become more difficult, where in the past we only needed to target H1C and most of us were failing. Now you've got 5 other components. So what the studies are showing is that only about 40 to 50% of people, look to the left of this graph, are reaching an H1C below 7. That only 30 to 50% are getting to BP targets. That only around 30 to 50% are getting an LDL target. In fact, not all patients are on statin. And if you take every component, H1C, blood pressure, and LDL, just those 3 without obesity, very few patients are actually reaching targets. So only around 19%. And if you add weight, only about 7%. So what we need to do is look at our patient and say, what am I going to give this patient? We've got to individualize the treatment. And you can only individualize treatment if you know what each one of your weapons or your tools is going to achieve. So let's start on the bottom. When we look at insulin, the risk of hypoglycemia is very high. And there's definitely going to be weight gain because it's a growth factor. The newer acting insulins that are longer acting, that are more predictable, seem to have a slightly lower risk of hypoglycemia than the traditional intermediate acting and the short actings that we were used to using. The weight gain is there, but a bit less than the old-fashioned insulins. If we climb up with the SUs, most of us grew up being very comfortable using the SUs. The problem is the risk of hypoglycemia and increase in weight gain. When we combine insulin with the new GLPs, the risk of hypoglycemia is there. And depending on which agents you're using, you may either be weight neutral. So some of the GLP will negate the weight gain effects of insulin. And some of the newer ones will, in spite of the use of insulin with GLP, will actually have weight loss. The pioglitazones, risk of hypoglycemia is minimal, but there is weight gain, mainly water retention. Metformin does not cause hypoglycemia and is weight neutral, and in some studies even showed weight reduction. The DPP-4 inhibitors have trumped the SUs. Definitely no need to use SUs anymore now, because your DPP-4 inhibitors can achieve the same amount of HbA1c reduction without the risk of hyperglycemia, without weight gain. But the Rolls Royces are the SGLT2 inhibitors, which are oral agents, no risk of hypoglycemia. It's an insulin independent pathway and actually drops the weight. And if you look at GLPs, the injectables, no risk of hypoglycemia and has a massive weight reduction. And so remember that 85% of our patients with type 2 diabetes have obesity as the underlying problem. And as we introduce products that are going to drop the patient's weight, we can look towards remission. We can look towards saving those beta cells. And so I'm not going to go through the old-fashioned meds. You guys know about those, but let's speak about SGLT2, which is an insulin-independent pathway. And what happens is that you and I, as a protective mechanism through the evolutionary pathway, when there is too much glucose, we're going to spill the glucose. And for most of mankind's life, nutrients were a scarcity. So you're going to try and hold on to your glucose as much as possible. So what helps you hold on to glucose? It's the SGLT2 and the SGLT1 receptors. These receptors and channels are found in the nephron, And what they do is they allow you to reabsorb the glucose, and by inhibiting SGLT2, you will then allow glucose to be spilled out, and so that then drops glucose levels in a diabetic patient. And so you're losing about 420 grams of glucose on a daily basis, and that is how the SGLT2s work. In terms of the pros, they do drop the HbA1c. There is significant weight reduction of anything between 1.5 to 2.5 kilograms. And these were studies done over a 6-month period. In my experience, having used this product for a long time, and we've done clinical trials, the weight loss is a lot more with time. It drops systolic blood pressure. It can be used alone. It can be used as an add-on. It can be used as a combination drug. And what's important to note here is that for over 100 years in all our guidelines, metformin was always the first agent of choice to be used. And for the first time, the cardiologists in Europe published in their guidelines that the first line of treatment from their perspective in patients with type 2 diabetes is an SGLT2. I seem to disagree with them. I think it's not about competition, about one against the other. I think the message that needed to be sent out is that you probably want to be starting with metformin and an SGLT2 as a combination drug from the beginning. Very low risk of hypoglycemia, if at all. And then depending on which product you're looking at, there's varying cardiovascular benefit, but all the ones in South Africa show cardiovascular benefit. Cons, slightly higher risk of UTIs, but that's only if the patient's not drinking enough fluid. What we do see is if that patient's prone to STDs, it will worsen. And the reason for that is, of course, you pee the sugar out, but before you pee it out, it's sitting in the bladder. If you colonized with the bug, you're feeding it. So what we have in South Africa is EMPA on the first column and DAPA on the second column. And the doses for EMPA is, the product's called Jardians, and it's 10 to 25 milligrams. I go straight to 25 milligrams and use it once a day with or without food, so it's easy to use. In terms of DAPA, it's a 5 to 10 milligrams. I go straight to 10 milligrams. The product's known as Forxiga, and also with or without food once a day. And this is why they're here to stay. So if you look in the big clinical trial, and this was the first clinical trial published with cardiovascular benefit in terms of an oral agent, 14% reduction in terms of 3-point MACE. That's taking into account cardiovascular death, non-fatal MI, and non-fatal stroke. And so this was the game changer. But what I want you to look at is also the 35% reduction in cardiac failure if you use this product early. And I just told you that cardiac failure is very common in diabetic patients. Now, all of us have seen these Kaplan-Meier graphs before, statins, for ACEs, for lots of other things. But whenever you look at those graphs, you always see a divergence, which is what you want to see, around 6 months or a year. If you cast your eye to where the circle is pointing, you will see that from day one, there is divergence in the curve. That's important to note. And there's been many thoughts around how come this product is seeing results so early on. Cast your eye to this one, the first one again. Look, the separation in the curves is within the first month or two, unseen. We don't even see this with the statins. We don't see this with the ACEs. So that means this product is doing something unique that nothing else has done. And my theory is that because you peen the glucose out, for the first time, we're seeing the devil out of the room. Whereas with every other product we used, we're always just moving it into a different part of the body. So it's just like shuffling the deck chairs on the Titanic. Whereas with this guy, the devil's out of the room straight away. In terms of decreasing nephropathy, a 39% reduction with the use of this product. So it's amazing that we have cardiovascular, renal protection, and then of course it goes without saying microvascular. What about some of the newer injectables, so the GLPs? And there's 4 in the South African market. There is the exenatide short-acting Byetta, which is a morning and evening injection. There is Victoza, also called liraglutide. That's a once-a-day injection. There's the Rolls-Royce, which is semaglutide and dulaglutide. These are once-a-week injectables, and they've been game changers. And so the reason why the game changers is that GLP, if you look at the mechanism of action, it works by getting that beta cell to secrete the insulin in a more clever fashion, and it actually switches off insulin production once the glucose level goes below 3.6. So it's got like an internal sensing mechanism that prevents hypoglycemia. But more importantly, you see, in a patient with type 2 diabetes, they continue producing glucagon when they're not meant to. You see, if you and I have not eaten, let's say our last meal was 8 hours ago, we know that after our last meal, we're going to have a glucose excursion for 2 hours. But what are we going to survive after 2 hours? That means the body has to continuously produce its own glucose from glycogen. So what drives that pathway? Glucagon. So glucagon will only produce endogenous glucose when it's needed. But when you're eating, it switches it off. Whereas in diabetic patients, that mechanism is not switched off. That means you're getting glucose from the outside, and you're always getting glucose production whether you need it or not because of this abnormal glucagon response. And GLP addresses that. And never in the past have we had a molecule that addresses that component. But also, GLP decreases gastric emptying. So instead of just dumping all the glucose that you've eaten, it slowly releases it so that the glucose excursion is spread over a longer period of time rather than a peak. And that it decreases hepatic glucose production, I told you. And more importantly, it makes the patient feel fuller earlier, so they eat less. So that's the ace behind the GLP molecule. And so the pros are, it drops HbA1c, it doesn't cause hypoglycemia, it can be used on its own, it can be used as an add-on, it causes significant weight reduction, and it drops blood pressure as well, and it has cardiovascular benefit. The price you pay, a bit of nausea, vomiting, and this is an old slide. The discontinuation rate is much lower because now we tell patients, start off at a lower dose, bring the injection as close as possible to a meal time, and then take a week or 2 or 3 to slowly up titrate, and then the discontinuation rates are much lower. There is no risk of pancreatitis, the newer studies are showing, so long-term follow-up. And the reason why this is an ace in your sleeve is that, look at this primary outcome. The liraglutide molecule, which is Victoza, showed a 13% reduction in cardiovascular death, non-fatal MI and stroke. Now, never have we seen an injectable product do this. This is an old slide of the first study. After that, there's been many other studies showing in the other GLP molecules this kind of data. The product works better in somebody who is older. So in both people below 75 and above 75, there's benefit, but the older patient has more benefit on this. If somebody has underlying cardiac failure, look to the right, the benefit is even more. And those without cardiac failures, of course, do benefit. And I showed you that it decreases progression to cardiac failure. And more importantly, if you've got patients with renal dysfunction, especially with GFR below 60, the reduction in MACE is much bigger. And in patients with microalbuminuria, patients leaking albumin, which is not a good thing, and it's common in our patients with long-standing type 2 diabetes, there is a significant 17% reduction in MACE. Now, your biggest nightmare. These are the new guidelines. So in the past, and let me remind us, we were not successful when it was as simple as diet and exercise. If the HbA1c is not below 7, add metformin. Give them 3 to 6 months. If the HbA1c is not below 7, add an SU. Give them 3 months. If the HbA1c is not below 7, add insulin. If basal insulin is not enough, biphasic. If biphasic is not enough, basal bolus. So simple stepwise approach with one target in mind, HbA1c, and we all failed. And now they've given us this new guide. How's that? So what's important for you to note, it's a very busy slide, but let me take you through it. And if you follow this logical steps that I'm telling you, it's going to become easy to manage your type 2 patients. First line therapy at this point in time, world over, unless you're a cardiologist in Europe, is still metformin. I can tell you what's going to happen in the future. It's going to be metformin and an SGLT2 as a combination therapy. At every level, the patient needs to be physical, getting 10,000 steps a day, and needs to be watching their weight. Now, as soon as you've got a patient with type 2 diabetes, in your mind, ask yourself this question: is there established cardiovascular disease or kidney disease? If the answer is yes, ask yourself the next question: is this patient dominating in atherosclerotic cardiovascular disease? If the answer is yes, after metformin, it's a GLP. If you use an injectable GLP and the patient has a side effect that is not going away, add an SGLT2. If the patient has got no side effects to a GLP, carry on. If you don't reach target, add an SGLT2. If you got a new patient and you say, this patient does not have established atherosclerotic disease, but has some kidney issues, GFR is a bit of a problem, or the patient has heart failure that is not so much atherosclerotic, you start with an SGLT2. If the patient is doing well but has not reached target, add a GLP. If you gave the patient a SGLT2 and they got side effects, start with the GLP. So in short, if you got a newly diagnosed diabetic patient and there's atherosclerotic cardiovascular disease or heart failure or CKD, you will not go wrong choosing an SGLT2 or a GLP, and you must. That's what every guideline, that's what every cardiovascular study is showing. The second consideration is you've got a diabetic patient, you've spoken about kidney and heart failure and atherosclerotic. Ask yourself the question, I need to minimize hypoglycemia, because we know that hypoglycemia increases cardiovascular death. So your next agent is going to not cause hypoglycemia. So after metformin, you have to think about either a DPP-4 inhibitor, a GLP, a SGLT2, or the TZD. So take metformin and any one of these. If you got to target, carry on. If you haven't got to target, add one of these that are already in the 4. So on the DPP-4, you add a SGLT2 or a TZT. On a GLP, you add a SGLT2 or a TZT. On a SGLT2, you add a GLP, a DPP-4 or a TZT, and so forth. The next consideration after hypoglycemia is my patient going to put on weight, or is my patient already obese? If the answer is yes, go for a GLP after metformin. or an SGLT2 or both. If either one is being used and you're not yet on target, use the other. Let me summarize. You've got a diabetic patient. They've got to watch what they're eating. They need their 10,000 steps a day. And you're going to emphasize that at every visit. After metformin, cardiovascular disease, mainly atherosclerotic, GLP. Cardiac failure, SGLT2. Kidney issues, SGLT2. At any point, if those products are not enough, add the other. If at any point you got side effects, add the other. Next consideration, I don't want my patient to get hypos. That means no SUs, no insulins. It's DPP4, GLP, SGLT2, or TZD. The next question, is my patient overweight? Yes. GLP or SGLT2. Is my patient overweight? No. Is my patient going to become overweight? Yes. GLP, SGLT2. And only cast your eye to the complete right. If cost is an issue, then you're going to go to an SU and a TDS. And keep in mind the Hippocratic Oath. Always do, first do no harm. And now every guideline is saying individualized treatment. We know with weight gain comes harm. We know with hypoglycemia comes harm. So keep that in mind. What are the common barriers to achieving target? We spoke about it. Hypoglycemia, weight gain. Don't make the regimens complex. Cost becomes an issue, and adherence. And this is especially what we see in patients that are already on insulin. And so, again, keep in mind, before we choose insulin, hypoglycemia needs to be kept at a minimum. That's what the guidelines are showing. So, I'm going to just skip this one. Now, once you've done all the oral agents and you failed, then you need to be looking at the algorithm in terms of initiating insulin and intensifying insulin. Here, once you've got an HbA1c above 9, you're already on dual therapy, you need to be looking at insulin. If you're on triple therapy and you're still not on target, you're looking at adding insulin. It can be either added as a basal insulin or a combination, either twice a day or 4 times a day. What's important is to keep in mind that if the regimens are complex, the patient's compliance is going to go out. That is why you see there in the middle, consider always having GLP on board, because GLP will decrease your requirement for insulin, will negate some or all of the weight gain effect of it, but also protect from a cardiovascular perspective. So let's remind you, what are the challenges the patients face? Because you've got your own challenges. But remember your patient saying, I've always struggled with my weight. Now my doctor wants me to go onto insulin. What's that going to do to my weight? In the middle, I've had hypos before. I'm scared. Or my father had hypos. They rather keep their HbA1c high than allow it to go low and increase the risk of hypoglycemia. What's also on their mind is that if they go onto insulin, they're scared that they're going to get more hypo. Let's look at the third column. After trying many medications, my HbA1c is still high. They feel like they're failures. Now my doctor wants me to give myself basal bolus. That's going to be so difficult. So many injections a day. So let's start with case 1. Mr. LM, 63, type 2 diabetes from 2015, has already established microvascular complications. He's on an ACE, a statin, metformin, and an SU. BMI of 31, so already obese. Blood pressure not bad, LDL not bad, waist circumference horrendous, HbA1c of 10.8. You've got the patient on metformin, you've got the patient on an SU. After reinforcing the importance of lifestyle modification, what next? So most of us in the past would have gone on to an insulin. Now we can add an SGLT2. And an SGLT2, I had a patient similar to this at Bera, refused to go on to insulin. We don't have the GLPs, and said, but doctor, there must be something. And I said, listen, we don't have it here. Now we do have it. We have an SGLT2, but at the time we didn't have it. And I said, well, there is a drug on the market, but it's costly. It's about $400. We don't have it. She said, I'll find the money. She went on to an SGLT2, came back 4 months later with an HbA1c that had moved from 12 to 5.8. So although the study showed that the SGLT2 can drop it by about 1 to 2 percentage points, sometimes our patients surprise us. And so this is the patient. I stopped the SU, initiated the SGLT2, and this particular patient's HbA1c came to 6.8. The one at Bera actually dropped to 5.8. But more importantly, the blood pressure improved and the weight started coming down. She was a female patient and she was ecstatic. Here's patient John, uncontrolled on metformin and on basal bolus. Let me remind you, basal bolus is a long-acting insulin with 3 short-acting insulins, one before each meal. Patient always had hypoglycemia avoidance behavior, has diabetes for 8 years, started on insulin, originally HbA1c of 10.2, now 9.9. BMI has gone high, and in total using 120 units of insulin. So this patient's actually allowed me to share the name with them. I'm not going to share it, but it's a very well-known politician, left politics. He's an advocate. And I can tell you he's a sterling example of somebody, your model patient with type 2 diabetes. And the reason why I say always have in the back of your mind remission, even when you got a patient with insulin use. This patient came to me exactly like this. And what I did was I put him on a GLP. At the time, now you get it in a combination, but at the time it wasn't available in South Africa. We had done the clinical trials and he managed to get it in Dubai. And we added GLP, and a year and a half later, we completely reversed his diabetes. He was completely off insulin, and his waistline is now like mine. And so, and he's managed to keep this up now. I mean, I've been treating Mr. Posa for over 5 or 6 years, and he's always said, when I'm ready, he's willing to come and talk to my students to talk about diabetic remission. But nowadays, you get a combination of insulin and liraglutide. And what you do is if you got patients on insulin, let's say the patient's on Novomix, 30 units in the morning and 12 at night. So that's a total of 42. Or another patient may be on Glargine, 60 units once a day. Or there may be another patient on basal bolus, like this example that I just showed you. What I do is this particular pen can go up to 50 units of a long-acting insulin. The half-life is over 25 hours, and it's got liraglutide. And what you do is you start off. If the patient's only been on oral agents, you start off with 10 dose steps. So you just dial to 10 units. If the patient's already been on insulin, like this particular patient here, I go straight to 16 units. And on the left, it shows you how much liraglutide GLP you're getting. And on the bottom, it tells you how much long-acting insulin you're getting. And what I do is I tell the patient, take your 3-day morning average sugar levels. If it's above 8, increase it by 2 units. And every 3 days, continue to increase it. And then what happens is the patient will dose titrate it. And when the 3-day average is below 8, they can stop and wait to come and see you. So you can go up to 50 units, where you're going to get 50 units of degludec and 1.8 units of liraglutide. And on this patient, we went up 40 steps. So we didn't have to go to the maximum. And the HbA1c dropped to 7.1, lost 7 kilograms, no significant hypoglycemia. But more importantly, from basal bolus, a complex regimen of 4 times a day, just to once a day, the patient started feeling less hungry, felt more control in their lives, and it was easier to manage. So, you know, there are so many new insulins, there are so many new GLPs, there are SGLT2s, there are so many different combinations. No one 40-minute talk is going to do justice to you being taught every regimen. The key thing is individualized treatment. Know what each product does. Don't be scared. And every time a patient steps into your practice, think, can I still cause this patient to go into remission? So where you can, once daily dosing of 2 medications in one device as an injectable is always first prize. And that goes to oral agents as well. Where you can use a metformin and an SGLT2 that doesn't cause weight gain, that doesn't cause hypoglycemia, always first prize. And it improves cardiovascular benefit. When we're using the injections, second column, reduce injection burden, fewer injections. Fewer injections means less testing. Less testing means you're saving on strips. It's going to improve compliance in the third column. And lastly, it is cost effective. So there's a whole talk on the pharmacoeconomics of GLP against insulin and what the medical aids are currently paying for. And it's a no-brainer. It at the end works out much cheaper. So you need to keep medical costs in mind. Use cost-effective medications that are not only going to improve glycemic control, but decrease microvascular complications. And if your patient lives long enough, they've got a 100% chance of getting a heart attack, stroke, or kidney failure, or amputation, or being blind. So keep that, the cost of that in mind. So I'm going to stop it there, and I'm going to stop sharing so that I can, oh no, I can still look at your questions here. So I'm going to look through the chat box and let's see if there's any questions. What is the risk of semaglutide?
Sure. Yeah, sure. That's great. Yeah. So,
Yeah,
okay, go ahead. Yeah.
pancreatic cancer and thyroid cancer. All right. Dr. Bila, do you want me to answer the question or do you want to?
Yeah, normally I read them, but these are difficult words. I've never heard of some of these drugs. So it's easier for you to read them, I think, but it's okay. We'll see how it goes. But the one that we can start with, Gavin April, I'm not sure if that's when you're reading. Yeah.
Okay, so good.
I understand why you got the best
Right.
award for a teacher.
Yeah. So let's look here. Gavin April says, thanks for very informative. I have a patient who is currently on 140 units of Tegeo. Now, Tegeo is a long-acting insulin. So it's 1 up on the glargine and 2 up on the protofin, right? So the long-acting insulins and the newer analogs are more predictable. What do I mean by more predictable? In the past, the patient came to me at Bera. They injected 40 units of protofin, and the patient comes in the morning, and I said, what's happening? Your sugar levels are high. I swear, doctor, I only ate 2 slices of bread. Next time they come, same units, and the glucose level is low. That's because the insulin was not very predictable. So the newer agents, so like degludec, Tegeo, these are all more predictable. And this patient was given Epidra, which is short-acting, ultra-short-acting insulin, 25 units 3 times a day. So if you do the maths here, you are using over 225 units of insulin. And so this doctor very cleverly gave Trulicity. Oh shit! Sorry, I just moved this whole thing off now. So gave Trulicity. Now Trulicity is semaglutide's competitor. It's a once-a-week injection. The molecule is called dulaglutide, and it's the GLP. So it's going to improve the patient's satiety. It's going to decrease hypoglycemia. it's going to decrease the patient's weight. If the weight comes down, they need less insulin. If they eat less, they need less insulin. And so this once a week injection allowed this doctor to drop the Toujeo to 40 units at night. And I can tell you, if they continue and if they had to add an SGLT2, shit, man, I don't know what's happening with my mouse here, but it just doesn't get to the bottom of this question. It seems to, here we go. And they managed to get rid of all the short-acting insulin. So fantastic. Here's another example of a colleague of yours that had done exactly what I've suggested, and it's worked. I would go a bit further and tell this doctor to add an SGLT2, and you'll probably get rid of the Toujeo completely. How do I introduce or replace another patient on Novomix? You see, this is a very interesting question. You see the bloody guidelines, and the companies, they don't tell you how to transition from one product to the other. They say stop and start the other one. We all know that products take a while to kick in. So what I tell patients is, let's take this patient, Novomix, 30 and 80. And so, 80 units in the morning and 50 at night. Now, if I want to introduce either Ozempic or Trulicity to this patient, I start them on that product and I tell the patient, increase your insulin by 2 units, morning and evening every 3 days. And you slowly go up on Trulicity or Ozempic because it can cause nausea, bloating, and loose stools. So you start off low and build it up. So the first month is low dose, and second month onwards, it's 0.5 a higher dose. Whereas Trulicity, they don't allow you to up titrate. It's a fixed dose. And so what happens is the patient will slowly lose their reliance on insulin, and slowly the effect of Trulicity will, or semaglutide will go up. So it's a slow transition, and give the patient the control. And what you tell the patient is check your morning glucose levels. If it's above 8, don't reduce. If it starts getting below 8, start reducing it by 2 units, morning and evening. And slowly, you are able to decrease most patients' insulin requirement by anything from 30 to 50% within the first month or 2. So now I'm going to just go down and look at some of the other questions.
Yeah, the next one is from Kevin Alexander. What is the risk with semaglutide or pancreatitis, pancreatic cancer, and thyroid cancer?
Very good questions. So the first GLP that came out, we did the clinical trials. It was called exenatide. And as you know, exenatide, all these clinical trials happen on mice. So the company will choose a mouse model, and so it's one model. So in other words, if you have to look at the entire kingdom, a zebra is different to a donkey. So like that, in mouse models, they're all different. So the mouse model they chose, and they didn't know it at the time, with the exenatide, some of them got medullary cancer. So now the signal went up to say, oh shit, good luck, but it can cause potentially cancer. So what they did was they tried it on other mouse models. And on every other mouse model, nothing happened. Then they realized that genetically, this mouse model was prone to medullary cancer anyway. And so that's why it increased it. So henceforth, the FDA forced every company that was going to do a launch or a clinical trial on a GLP to do studies and vigilance studies to look for medullary cancer. And to date, they haven't found any. So unless you've got a patient with medullary cancer, you can use this product. If the patient's got medullary cancer, thyroid cancer, you can't use it because it will worsen it, right? And so those conditions are very rare. So it doesn't cause it. But they have to put the warning in now because the first mouse model had it. So they can't take that warning out. That's how clinical trials are published. What about pancreatitis? So in the first wave of these products, there was some pancreatitis. So people thought, oh shit, this product causes pancreatitis. When they continued and they looked in the placebo arm, they realized that diabetic patients by themselves have a higher risk of pancreatitis than the general population. And so those risks were matched. So what we say is that if you've had a history of pancreatitis, please don't give it to the patient. If they had no history of pancreatitis and they are not binge drinkers, you can go ahead and use it. The risk of pancreatitis is no different with any other diabetic product. If you got patients with gallbladder disease or gallstones, your GLPs are definitely going to worsen it. So you need to caution. So that would be the only issue I would say. And pancreatic cancer, no. If you look at even, I mean, now we've got lots of patients, but about 8 years ago, they already had about 6 years ago, they already had about 8 million users over a long period of time and not one pancreatic cancer recorded. But if you've got a cancer, of course, don't use it, you don't promote it.
Yeah. Next question is, thanks for that response from Sheena Janice. Is there any place for the intermittent fasting in diabetics and using medication during the eating window?
Oh, no, definitely. I mean, if you come to Bera, Dr. Pauly has allowed diabetic patients, type 1 patients who want to come off insulin or want to decrease the dependence on insulin to come for special education, and we teach them how to calorie count and go on a completely carb-free diet. And we've got patients that have managed to come off insulin completely. And in most of those 100-odd patients, there's been at least a 30 to 70% reduction in insulin use. Remember, most of you have been to a game reserve. See the lion eating sugarcane or apples. No. Lion is a mammal. It only eats another animal. And no animal's got carbs. We mainly made up of protein and fat. So from a survival perspective, just go back. 100 years ago, you didn't have mealies. You didn't have apples on your table every day. You weren't like me, a vegetarian. Those days, vegetarians, they had no place. You speared an animal and you ate it. Raw, or if you knew how to make a fire, you partially cook it. So from that perspective, we all grew up on a paleo diet. Metabolically, that's what we're geared to do. So when you do intermittent fasting, what you're doing is you're getting your body to get to a point of ketosis where it survives on ketones. And so doesn't rely so much on glucose. And in that case, that patient is definitely going to use less insulin. So a word of caution, the patient needs to know how to count. And the patient needs to, a diabetic patient needs to understand that they need to monitor themselves. And so when they do intermittent fasting, they will definitely benefit. So you don't have to take my word for it. What did we do 100 years ago when there was no insulin? In the 1800s, when a patient had diabetes, what was the advice doctors gave that mother in a new child who's got type 1 diabetes? They were told that your child's going to die in 3 days, unless the child completely avoids all carbohydrate. And so before the advent of insulin, that's how type 1 survived. They didn't do well because there was always a bit of carb involved, but the more they stayed away from carb, yes, they were thin. Yes, they were marasmic looking, but they survived. So intermittent fasting, if you make yourself knowledgeable, whether you're diabetic or not diabetic, there will be benefits. And so to know how to use it.
Sure. Now we're going to nephrology. Azwindile Mulaus wants to know what would be the lowest eGFR beyond which one should not opt for SGLT2 inhibitors. Tamlazi wants to know.
All right. So at the moment, we've got to follow what the clinical trial has shown and that company's registration. And that will vary from country to country. So in terms of the current products we got in the South African market, you got a GFR below 60, you will benefit from an SGLT2. You've got a GFR below 60, you will benefit from a GLP. Once you've got a GFR below 30, tread with caution. Being a nephrologist, you may want to take your chances. The rest of you, stay away. You're not allowed to use an SGLT2. The reason why I say the nephrologist may want to give it a trial of treatment is they carefully monitor that UNE. And remember, This product is already in clinical trial in non-diabetic patients with renal dysfunction, in non-diabetic patients with cardiovascular issues. So these are still clinical trials, but follow the registration in the country. And at this point in time, below 30, can't use. GLPs, you can still use, and you can use it up to a GFR of 10. Once it goes below 10, you probably want to be cautioned. I hope that answers your question.
Sure, Dr. Mlaus. Sure. Excellent talk. Your opinion on the use of giants for weight loss, that's from your friend, Dr. Murray.
So, well, I'm assuming they're talking about off-label use here. It's a no-brainer. They're going to lose weight. And they're going to lose weight with the GLP as well. And so remember, the GLPs have been registered overseas as a weight loss product. And in South Africa, Saxenda, which is a high-dose liraglutide, has been registered for weight loss. And because it doesn't cause hypoglycemia, it's wonderful for weight loss. And then if you look at patients who are on semaglutide, about a quarter of patients will lose about 15% of the weight. About another quarter will lose at least 10% of the weight. Another quarter will, another 30% will lose at least 5% of their weight. So as a weight loss product, it works. Semaglutide is not currently registered for weight loss in South Africa, but overseas it has at a higher dose and excellent results. I was recently at a launch of a new dual peptide, a GLP and GIP, and there 1/3 of the patients will lose 1/3 of their weight. So the day of bariatric surgery has now ended. In the next 3 or 4 years, there are so many new molecules coming out that will trump bariatric surgery in terms of weight loss. And remember, these semaglutides are available in oral agents. We've just done the clinical trials, and in a few years' time, they're going to be launched here as well. So it's a very nice time in one's life to be a diabetologist or an endocrinologist. Lots of exciting things in this field. But like I said, it's because of these drugs you can look towards going for remission and reversing diabetes. The short answer is your SGLT2s at the moment cannot be used as weight loss because it's considered off-label, and you can do whatever you want to with that information.
Thanks very much. We seem not to have any further questions. Just gratitude from most people. We even have someone from Kimberley.
Yes.
Joseph William. We know we get people from all the way from the Western Cape, so we're looking at it every week. And say thank you very much for your very insightful presentation. Colleagues, I don't know if there's anyone else who has a question. If you have a question, you can just unmute yourself and ask a question.
Okay, I see 75 of you. There must be somebody with questions. Go for it.
Yeah, we were 200 actually. Anybody else has got a question from the colleagues who are in practice, or any of your students who have been seen you for a while now that you on the sabbatical? It was quite a shock when you mentioned the fact that with this, that whole presentation and that stepwise approach is no longer an encouraged way of managing diabetics. But is there I know that's slide that you showed, but is there no shorter version that you can share with maybe GPs to say how do you manage patients from their practices? So that, because this is quite new information from what I hear.
So I think, Ray, you've always known that I'm not a very cost-effective doctor. And, I think short-term savings is a long-term cost to the pocket. So for me, it's a no-brainer. Every one of my patients, irrespective of their H1C, from day one, are on metformin and SGLT2, and depending on the cost, depending on the presence of fatty liver, and looking at their weight, they may or may not be on a GLP. And in fact, most of my patients go into remission in a matter of 6 months to a year. So I always tell patients when they're referring patients to me, Don't send them to me unless they want to reverse. If they just want to be well controlled, all of you guys can continue doing that. That's fine. That's just follow the guidelines and you're going to do that. But
Yeah.
definitely, you can go into remission. And many patients have gone into remission. You know, one of the questions here is saying, is it better to switch from Victoza to Trulicity weekly? Yeah. The data on the once a week is much better than the daily. Compliance is better. Weight loss is better. Cardiovascular benefit is a bit better. Results on fatty liver are better. So whether you're going for Trulicity or Ozempic, yeah, the data is much better than the once a day injectable GLPs.
Yeah. There's a question sent to me directly. They want to know how rapidly does weight loss begin after introducing all these measures, these combination therapies that you're talking about?
Very, very good question. So in terms of the GLP, once you start a GLP, don't count the low dose, because let's say you started somebody on Byetta. The first month it's 5 milligram pens, and it's an injection in the morning before breakfast and one before supper. And so for the first month, it's not going to do much. From the second month onwards, you're going to go to 10. And then once you've been on the 10 for at least 3 months, you should have had at least 5% of your weight gone down. If you do, carry on. It's going to keep going down. If you haven't, abandon treatment. That is not the major pathological pathway with that patient's type 2 diabetes. If the patient was on Victoza, you start on 0.6 the first week, then you can go to 1.2, and then you can go to 1.8 stepwise. So once you're on the maximum dose that is prescribed for that product, 12 weeks, you must have at least 5% weight loss. If though, carry on with any of these. What kind of weight loss I've had? The highest I've had is a patient who weighed 200 kilograms and he lost 87.5 kilograms. The second highest weight loss I've had is about 60 kilograms. But typically, most of my patients end up, but remember, as an endocrinologist, we're doing a few other things as well. We're working on the fatty liver. We work on a few other things. Typically, most of my patients lose anything from 12 to 18 kilograms. That's why we're heading for remission. Is the generic Genumet as effective as Galvesmet? They're both generic. Yeah. I mean, so look, yeah, the short answer is yes. Yeah.
Okay.
Yeah, most of the companies come up with their own generics first now. So Galvus and Jalra come from the same factory. So that's why they're equally effective.
Okay, please mute yourself there, please. Okay, you want to go ahead?
Now I see there's another question. You know, I hate this question. Which funder is paying for SGLT2 and GLPs? So, you know, these guys play cat and mouse. In the past, they used to say, no, we only have to give whatever is equivalent to the state. Now, in Vera, I've got patients on SGLT2s and on DPP4s. Now they say, no, it depends on what's on the EDL. So they're always going to be playing games. And, you know, a lot of them don't mind paying for GLPs. And depending on which medical aids, they don't even mind paying for the GLPs. So SGLT2s, all of them pay. Some of them need a motivation, and they've got their criteria. GLPs, some of the top medical aids are paying for it already. Of course, the patient needs to be shown to have an HbA1c that is still not in target and have got underlying cardiovascular issues. So if you've got a diabetic patient who's had a heart attack, they pay for it. You've got a patient who's diabetic or a stroke, they pay for it. That's a no-brainer. It's when the patient does not have cardiovascular issues, that's when they're a bit reluctant. Yeah.
Sure. Yeah. No, thanks a lot. I didn't talk to him, but we've got Professor Joe Varieva in our midst. You know, he works with us at clinics as one of the risk committee members to give us. I'm going to ask him to give a closing comments. You know, I'm sure you've worked with him. He's one of us elders in the medical fraternity. I don't know if you want to say something, Prof.
Yeah, thank you very much, Dr. Bhana. And I think it was a very exciting overview of all the new developments. And I agree with you that, the point you made when it came to first line and second line. The American, I think, Cardiac Society said the first line was metformin, and then if the sugars don't come down, you add on an SGLT2 inhibitor. But I agree that one should probably use both, because in hypertension too, we've now decided in many cases, instead of starting off with one and then adding on, so we often start off with two, maybe at lower doses. So that's there's no doubt that they benefit from these, and there are cardiovascular benefits. And the SGLT2 inhibitors have been shown, and as Dr. Bhana correctly pointed out, that it has a kidney protective effect. In other words, when the creatinine clearance is getting to about 60, it slows down the progression. It doesn't stop the kidney progression, but it slows down the progression. In heart failure, the amazing thing was that we didn't have any medication for heart failure that was due to diastolic dysfunction. In other words, where there was a preserved ejection fraction. And what we used to tell our doctors, if you've got a person with heart failure, you must do a cardiac echo, because then you want to see if there is systolic LV dysfunction, where you got a low ejection fraction, or you should go ahead and do, or whether the ejection fraction is preserved. And the SGLT2 inhibitors have now convincingly shown that the benefits for heart failure is irrespective of whether there is a preserved ejection fraction or whether there is a depressed ejection fraction. So these drugs seem to have benefit. My big concern is, and if you take semaglutide, it's one of the best, it has the best effect in bringing down weight when it was compared with all the other weight reducing agents. But what is very disturbing about this is bloody costly. That injection costs quite a lot. And when we get to this, what worries me about all these new things is that we are treating a specific cohort of patients who can afford many of these medications, whereas a lot of our diabetics do not have the money to pay for all this. And I appreciate what Dr. Bhana said about what you spend now, but the later benefits and that. But that does not apply in our setup. And we got a lot of obesity, and in fact, even amongst the poor, we are seeing a lot of what shall we say, diabetics coming up because of the high incidence of obesity and all that. In any case, I think that this was a very comprehensive overview, and you brought in the correct sort of studies that were used and all that. And I enjoyed your talk. I'm just hoping that many of these new developments become accessible to a broader population in our country, because the medical aid could also be rather difficult at times when it comes to usage here, and also the cost impacts on the reserves or whatever. But thank you very much, and behalf of the clinic's risk committee and all the people that were listening to you, thank you for an excellent presentation.
Thanks, Prof. Thank you very much for that comment. Prof, what's interesting is at the moment, in fact, your nephew and I, Brahmi from Klerksdorp and I, we've just published.
He's not my nephew, he's my brother.
Oh, sorry, your brother. Yeah. So
we all make that
just,
mistake.
we all do, huh? So, and that's, Prof, because you were the head of department when I was still a student, and Brahmi was just 2 years ahead of me. So we always, made that mistake. So apologies for that. But, we've just published a pharmacoeconomic paper looking at patients at Bera and some at his clinic. And we looked at over 200 patients over a period of a year in terms of what government is spending and in terms of the long-term costs. And it is far more economical if some of these drugs were introduced early. And, I hear you on the one hand, Prof, when you say, well, can we afford these drugs? And I would argue, yes. And I think we don't have enough of a voice as endocrinologists. But if you look at the amount of money HIV treatment costs, in the beginning, although tech fought the pharmaceutical companies in bringing the prices down, the cost of treating one patient with HIV treatment, triple treatment or dual treatment at the time, and the monitoring far outweighed the cost of any one of my diabetic patients. And yet the death rate from type 2 diabetes far outweighs. So I think it's about emotion, and this government is quick to say we don't have money. And yet during the COVID crisis, if you look, over $500 million spent on PPE and unaccounted for. So I think there is funds. I think it's misappropriated. I think we as endocrinologists have failed our patients in not presenting a strong voice to government and getting them to act. I mean, it took us a long time as SEMSDA to force them to get that sugar tax going. And a lot needs to happen. I mean, to address the obesity. I mean, we need to make protein-dense food cheaper. We need to be more vigilant with the amount of sugar and hidden carbs in food. We need to be starting education at schools. We need to bring in PE and become more active. There's lots of things. But as endocrinologists and diabetologists, I think we failed our patients. We're all quick to say it costs too much. I've got a whole talk on the pharmacoeconomics, and I gave a talk in Mauritius a few years ago, and there were some government representatives, and I heard a month later they introduced GLP for all the state patients. I launched a GLP product in Botswana, not knowing that there were two of the big funders in the audience, and the very next day they introduced it onto their formula. And I was asked to come and give a pharmacoeconomic presentation after the launch. So the issue is you need an ear that is willing to do something for our patients from a government perspective, and you need a strong advocacy group. But when we look at costs, the cost of dialysis, the number of, I mean, Prof, you know that Prof Dub published that book, and they, those days, because of apartheid days, every person who died in Soweto had to have a post-mortem whether they liked it or not. And so there was one death recorded in Soweto from a myocardial infarction in 1968. In those days, there was no clinics, there was no LandMed. Our patients never had access to Mill Park or any. So that's good data, because every death had to have a post-mortem. One myocardial infarction in 1968. And if you come to Bera now, we got over 5 or 10 admissions that are sitting with a myocardial infarction. Keeping in mind that those are patients that could not afford to go to the clinic's hospital or Lesedi or LandMed. A lot of them are, because they've got medical aid. So certainly we've seen that where in the past, our patients were not dying of heart attacks, they are. And so there is a role where government needs to come in and say, listen, myocardial infarctions, stroke, amputation, blindness, they're spending money on SASA. This is where the money needs to be spent in terms of getting the diabetic control done quickly, exactly like how we're managing HIV, exactly like how we're managing TB. I mean, if you look at TB and multi-drug resistant, the cost of multi-drug resistant drugs, it's horrendous. The money is there. And yet, more people die of type 2 diabetes than multi-drug resistant TB. And so I agree with you, Prof, but I think we need a stronger voice. They need to come to the party. The clinical trials are there. Products are good, easy to use. And if we use more, the costs will come down, because at the end of the day, that's the maths. You know, when you and I buy it, the cost is up. When government goes and buys a whole lot, they can bargain. I think it's about having the will to bring the right product to our patients.
Sure. Yeah, this kind of discussion comes up from time to time during this presentation, when you get such talks, when you get top clinicians and researchers like yourselves who can't bring this to the fore. So I think maybe in the future we'll have to bring in government officials to talk about how do we bring healthcare to the public at the cost that we think it's exorbitant, but benefits the public, ultimately. Before I give, there's a last question that I want, maybe you can handle it, we close. But before then, there's a request. Are you able to share the slide presentation?
Sure. I'll send it through tomorrow to the person who was communicating with me about the talk.
Yeah. No, that's fine. Yeah, that's Kamusu's. Yeah. So can you just take this last question and we close?
Sure.
We also done the Dr. Delmohan. Can one?
I'm not getting the question. I just got the last one that says informative talk.
It says, can one use SGLT or GLPs for non-diabetic, non-hypertensive client with asymptomatic progressively decreasing eGFR without any apparent underlying cause?
No. That's definitely off-label. So remember, we spoke about both the use of SGLT2 and GLPs in the context of a diabetic patient with renal dysfunction, with or without microalbuminuria. Those clinical trials are still happening. And so I would say for now, no, unless you're going to be using it off-label, in which case you just need to get permission from SAPCRA and let the company know that you're using the product off-label, and they're okay with it. I've done that. And so certainly your own colleague, the one who asked the other question, the nephrologist, maybe you can do it in conjunction with them. So yeah, it will be off-label use and one needs to get permission.
Okay. No, thank you very much. Professor just done the vote of thanks, and we just want to say thank you for accepting this invitation. As you said, you had noticed because the one person that we wanted that couldn't get, but we nonetheless very appreciative that you were able to step in, and we definitely, many people benefited. That's why we're asking for copies of the presentation. And on behalf of Clinics Health Group, we just want to say thank you, and also thank all the colleagues who joined in. We hope to have you again next week, and Gamo and the team for marketing for always being of assistance. And we hope to have you again next week. This whole month we're discussing diabetes.
Okay, very good. Good.
Yeah, we'll get different disciplines.
Yeah, I think what's important is, I mean, I just gave an overview. Somebody should give a talk purely just on SGLT2, GLP, and then there's, Prof mentioned it. Somebody needs to give in a talk on heart failure in terms of preserve and non.
We've got heart failure in 2 weeks' time. That's
fantastic. Fantastic.
Yeah. Others diabetes, the effects of diabetes on the eye, and also diabetic foot.
Fantastic.
We'll come back next week for those other conditions in diabetes.
All right. Good.
Thank you. Thanks, colleagues, and have a good night.
Bye.
Thank you.